Welcome to MSK Ultrasound of the Knee for Beginners. This video should serve as a supplement and introduction to the beginning AMSSM Basic Ultrasound Scanning course. We will be using an ebook format to review the basic cytoanatomy of the knee, as well as discuss scanning images and scanning protocols. We will start by reviewing the general introduction to the knee, talking about technique. We then will break the video down into sections, including the review of the anterior structures, medial, lateral, and posterior structures, including the posterior lateral, central, and medial. The knee is one of the most common injured joints. Its superficial tendons leads to it to be very amenable to examine with ultrasound. The most common evaluated structures are going to be the joint for an effusion, the patella and quadriceps tendons, collateral ligaments, and the posterior aspect to look for a Baker's cyst. Because so many structures are superficial, it is often very beneficial to use ultrasound to assist in diagnostic, as well as in accurately guiding a needle for procedures. The knee should be evaluated in a systematic fashion using a linear probe scanning usually from 8 to 15 megahertz. A curved linear probe may be useful for posterior structures. Having the knee in slight 30 degrees of flexion will help in the anterior exam. The other parts of the exam will be done with the patient either on their side or lying prone. Color or power Doppler may be also helpful, utilized during your ultrasound around the knee, particularly if there is an effusion, a cyst, or in a diseased tendon. We will be using videos from Essential Anatomy 3 as well as some templates from ESSR.org to help guide your learning regarding this area. On the anterior aspect, we will be looking at these major structures: the quadriceps, the suprapatellar recess, the femoral cartilage, patella bursa, patella tendon, and patella retinaculum. We will cover each specific area in a short video, going over great detail all of these structures. Let's start with our tour with the anterior knee structures. Our checklist includes the quadriceps tendon, quadriceps muscle, suprapatellar recess of the knee joint, the femoral cartilage, the patella and prepatella bursa, the patella tendon as both origin and insertion, and the patella retinaculum. Lastly, we'll finish with a simple quiz. The knee is best evaluated in approximately 30 degrees of knee flexion with the patient supine. This will help reduce anisotropy of the patella and quad tendons. It's best to put a small towel roll. Before we get into structures of the knee with sonography, we'd like to review the basic knee anatomy. Let's start by beginning our review of the anterior anatomy of the knee. We have the patella and the prepatellar bursa. The patella tendon attaches down to the tibial tubercle. The quadriceps tendon led by the rectus femoris, the vastus medialis, and the vastus lateralis. If we look underneath the rectus femoris, we see the quadriceps tendon formed by the three muscles above, as well as the vastus intermedius. Removing that will show us a small muscle, the genus articularis. Let's review the quadriceps tendon first in looking at this. The tendon has made a contribution from the rectus femoris superficially, the vastus medialis and lateralis on each side, and inferiorly the vastus intermedius. The tendon will appear multi-layered, which is important when you distinguish full from partial tears. When you scan the probe, place the probe longitudinally over the tendon and place the distal edge over the patella. Evaluate the tendon with a linear slide both medial and laterally as the tendon has significant width. In the short axial plane, we will evaluate the tendon from its insertion in the patella up to the muscle tendon junction and approximately 8 to 10 centimeters above on that. Let's look at some pictures here. Probe position here with 30 degrees of knee flexion. On a patient, it would look something like this. And this is what we would see: the patella, quadriceps tendon, suprapatellar bursa, the femur hyperechoic, and the fat pad sitting below and above. Looking at it on a short axis approach this way, we would see the quadriceps, small fusion, Again, the fat pads, femur below. Again, looking at this in greater detail, the quadriceps tendon, the fat pad here, looking at the joint on that, and lastly at the hyperechoic femur. Next thing we want to look at is the quadriceps muscle. The quadriceps muscle starts as a muscle tendon unit about 8 to 10 centimeters from the patella. The rectus femoris is the most superficial and proximal and has the longest muscle tendon junction. The vastus medialis is primarily muscular and it's the shortest, with most of it being muscular around the knee. The intermedius wraps around the anterior portion of the femur of the leg. We're going to scan in a short axial plane up the thigh. Here's a depiction of the anatomy, probe position, vastus intermedius, here, rectus femoris, medialis, and lateralis. A little further up the thigh, the rectus becomes a larger muscle, and we see the intermedius, again, medialis, and a little bit of the sartorius coming in, the vastus lateralis probe position here. Here's a long view of the quad, looking at it, with the muscle tendon junction coming down from the rectus and the intermedius. Let's look at scanning these muscles to get a better feel for that. The quadriceps tendon. To start looking at quadriceps tendon, I take the probe and place about a quarter of it over the patella. Once I'm over the patella, we can get a good picture of the zoomed in look at the quad tendon. Looking at its attachment into the patella, which is very broad. The top layer is the rectus femoris, then we have the vastus medialis and lateralis, and the lower layer is the vastus intermedius. Just below the quad tendon is the joint space here. To see that better, we want to change our depth and frequency down a bit, and we start to bring in the femur coming down below here and the joint space here. To see that, I can have the patient tighten his quad or extend his leg. We'll often look at that joint space in a little bit greater detail, and he doesn't have much fluid to see on that. And relax. We can follow the rectus up as well. We also want to look at this tendon across its width, so make sure you slide all the way laterally. Here you see a small abnormality at the proximal pole that he has in the attachment here, which is not uncommon, and then all the way to the medial aspect as well. We'll miss abnormalities if we don't scan across the whole width of the tendon. In addition, we want to do a short axis approach by looking at the tendon by placing our probe 90 degrees and looking at the tendon and muscle here in a short axis. I want to follow it all the way down, again, and I will zoom in again. Down here we see the part of the joint fluid coming in. Here's the quadriceps muscle coming down to the tendinous portion and attaching here to the patella. I then want to zoom all the way up the leg and move up the quad until I can see the different muscles. Again, dropping our frequency down and our depth down, we see the rectus femoris tendon here, we see the vastus medialis, the vastus lateralis, the vastus intermedius, and going up further, we see the femur down here below. Rectus femoris, medialis, intermedius, and lateralis. Structures we're going to look at will be the quadriceps muscle, where we're going to look at the following muscles in a short axis approach. We're going to follow them from the distal thigh all the way on up to the mid thigh. So we're going to start out by looking at the quadriceps tendon, the vastus medialis, the vastus intermedius, femur below, and the vastus lateralis. As we follow up the thigh, we will see the rectus muscle start to form into a muscle here and expand out to a full muscle. So rectus, vastus intermedius, femur, vastus medialis, and vastus lateralis. The next thing we're going to look at is the synovial recess and the fat pads, and take a slightly more detailed look at this area, as this is one of the most common areas that we're going to do procedures such as joint injections or aspirations. The synovial recess may extend approximately 8 centimeters above the patella and fill with synovial fluid in pathological states. To scan this is going to be a similar method that we did to use the quad, and we're going to evaluate the synovial recess both on its medial and lateral side. In order to detect the presence of fluid, you may find it beneficial to perform dynamic maneuvers by having the patient flex the knee completely or dorsiflex the foot to activate the quadriceps muscle. The examiner can also squeeze the parapatellar recesses with the non-examining hand to help detect small effusions. If needed, compression of the probe can also be done, and use of Doppler may help differentiate effusions from synovial thickening or inflammation. A short axial scan is also similar to the quadriceps tendon evaluation, but again, we're going to be looking at the bursa, more specifically lower beneath the tendon. This is particularly useful when doing your injections. Let's look at some of these views. Here's a view of the position, again, for the joint. Once again, our joint anatomy laterally, and again, our joint anatomy. Next structure we're going to be looking at will be the quadriceps and the suprapatellar joint and fluid from the knee joint. To best look at this, we want to do some dynamic tests. We'll again look at the knee joint in a long axis approach, lining up on the joint line in this manner here. You see that there's not much fluid in it. To bring much fluid into the joint, we're going to have him contract his leg and straighten it out. And when he does that, we'll see here that we just enhance the fluid of the joint here, and he has a small effusion. You should also note how far up that bursa or joint sac goes fairly far up from its attachment down where the quad tendon goes into the patella. So joint effusion right here. Relax. Once again, reviewing this most important picture and understanding your landmarks. Next, we'll talk about looking at the femoral cartilage. It's very important with ultrasound, and we can visualize this very well. The articular cartilage overlies the distal anterior femur. It's often pathologic in arthritic conditions. The cartilage can be broken down to 3 sections when using ultrasound: an anterior superior portion with the trochlea, the anterior inferior portion, and the posterior condylar portion, which we'll look at in the posterior aspect of the knee. When evaluating the anterior portion, in normal individuals, this cartilage is going to be very hypoechoic and of equal thickness. The trochlea is a V shape lying in the middle of the superior condyles. In full extension, it makes a path for the patella. Let's review this anatomy and talk about how we visualize these structures. The other anatomical structures we'll visualize with ultrasound will be the medial patellofemoral ligament located here. We will also want to visualize the femoral articular cartilage here, as we can see shadowed out by the patella. We'll see this cartilage in greater detail over the trochlear aspect on the superior view as well as the middle view. The posterior aspect will be difficult to see from the front. We'll have to visualize that when we do our posterior views. Here's a picture of the knee position. Note the knee is hyperflexed to look at the cartilage, which is V-shaped here on that. A blown up picture of the trochlear cartilage with the quad tendon above. Knee position for the middle portion of the cartilage. Again, a video showing the middle to superior portion here with the patella tendon sitting here. And then we want to look longitudinally at the cartilage on both its medial and lateral sides with the probe in this position. Cartilage here with quad tendon above and laterally. Let's look at how we scan this.
What we're look at is the femoral trochlea. To look at that, we bring the leg up into as much flexion as we can do. We place the probe down 90 degrees up top, and you should have a very good view of the femoral trochlea hypoechoic cartilage, which sits here. Here we have the quad tendon. It's important to look across the whole width of it, the medial aspect and the lateral aspect. We also want to look at this cartilage in a longitudinal plane. I'm going to take the probe and rotate it directly over it until I see my quad tendon come across attached to the patella, and then I look at the hypoechoic cartilage and I move my probe very carefully and subtly all the way across to the lateral aspect and look at the entire cartilage, and then I move it all the way across to its most medial aspect. It's important to look at across the entire length of that femoral cartilage to look for any abnormalities that you're looking for. This would look at the anterior superior aspect of the trochlear cartilage. To look at the anterior inferior aspect, we straighten the leg out and we're going to place the probe down at almost 90 degrees over the patella tendon, and I will look then for that same similar hypoechoic cartilaginous picture that we see here. I want to look across to the medial aspect of it, and I want to look all the way.
Again, reviewing the trochlear cartilage on that. Let's now talk a little bit about the patella. The patella is a sesamoid bone which fits within the quadriceps tendon as it sends fibers down to join up with the patella tendon. Just anterior to the fibers over the lower pole of the patella sits a small bursa. The bursa is a small hypoechoic area that's often not visualized on ultrasound unless it is filled with pathologic fluid. In pathological conditions, it will swell dramatically. When scanning this, place the probe longitudinally over the patella and use much gel to avoid excessive pressure, which might obscure a small bursal swelling. Confirm with short axial views. Here we're looking at a panoramic view of the quad and patella tendon here. Use copious gel. Small bursa, perceived sac which would swell with fluid, as in this case of a prepatellar bursitis. In looking at the patella tendon, is a very superficial structure that runs from the patella to the tibial tubercle. Sitting below it is Hoffa's fat pad. The tendon is slightly wider than the probe, so make sure you again look on both its medial and lateral aspects of it. At its insertion to the tubercle, a small, often imperceptible bursa is also noted, both anterior and posterior to the tendon. This is respectively the superficial and inferior bursa. When we scan this, we're going to be scanning similar to the quadriceps tendon with the knee in 30 degrees of flexion. You want to scan in both long and short planes, looking at the tendon in great detail. Be careful to avoid excessive pressure on the probe to avoid a subtle fluid such as a bursitis on that. Let's look at how we do this. First, some probe positioning longitudinally, looking at the patella tendon, its origin, Hoffa's fat pad, its insertion, subacute tissue, the broad insertion over the tibial tubercle. Panoramic view of the quad tendon coming in, sending fibers over the patella to the patella tendon with Hoffa's fat pad. And a short axis view of the probe position for the patella tendon would look like this. Patella tendon is pancake-like structure and Hoffa's fat pad, and again we see the femoral cartilage below, which we looked at previously. Let's look at how to scan this area.
The structure we're going to look at is the patella and the patella tendon. I'm going to start by our normal position by looking at the quad, and then I'm going to slowly follow down to the quad and look at the very top of the patella. The prepatellar bursa is a space which you will not see unless pathologic, but it would sit directly on top of the patella in this zone, and we kind of get a hint of it up in here, but it's not very obvious. We are now looking at the beginnings of the patella tendon. As I slide my probe down, I'm looking at the origin of the patella tendon into the patella. It has a broad attachment, and note that it goes all the way above and hooks up with the quadriceps tendon above. You really want to look very closely at the origin of the patella tendon, sliding your probe all the way laterally and sliding your probe all the way medially, making sure you investigate the entire width of that tendon. Just below the tendon is the fat pad sitting below. You want to follow the tendon all the way down to its distal attachment into the tibial tubercle here. It is a very broad attachment. Underneath the tendon is usually a small bursa, which we see a wisp of fluid here, which is normal, which sits underneath the infrapatellar bursa. We also want to look at that tendon in a short axis plane. We're going to do the same maneuver by rotating the probe 90 degrees and looking at the pancake-like structure of the patella tendon with its very, very broad width. Follow it down from its most distal aspect to all the way up to its proximal attachment, all the way into the patella.
The last structure we're going to look at is the medial patellofemoral ligament, the patella retinacula, and the medial articular facet. The patella retinacula are best thought of as a discrete thickening or the joint capsule over the anterior knee. The superior part of the retinacula inserts in the adductor tubercle and is often injured in patella dislocations, subluxations. The lateral structure also provides support and is important in patella tracking. Patella has multiple facets, actually 6, on its undersurface, of which the medial facets are the ones that may be visualized partially with ultrasound. To do this, you would need a small hockey stick probe to help facilitate this. Let's review how to scan the medial patellofemoral ligament as well as the sono anatomy of this area. Here's the position over the medial patellofemoral ligament. Here's what it would look like in its attachment, multi-layered on top with a joint below on this tibia patella. A blown up version of the multi-layered medial patellofemoral retinaculum patella attachment. The lateral patella retinaculum, which is less important unless they're having tracking issues. And looking underneath the patella here with a small probe, shining up underneath to see a small hypoechoic cartilage on the back end. Let's look at how to scan this area.
Our next structure to visualize is the patella retinaculum. We're going to start by looking at the medial retinaculum by placing our probe in this direction directly over the patella and look for the medial retinaculum sitting up top. The retinaculum is a bilayered structure sitting in this zone, sitting directly on top here, connecting here, and running all the way across to its attachment into the adductor tubercle. Sitting below it is part of the joint capsule, which we visualize here. The structure can be stressed slightly by taking the patella, grabbing it, and then pushing on it and trying to look at its attachment point to the patella, making sure there are no abnormalities in it. That is the medial patellofemoral ligament. In addition, we can also look at the lateral aspect of this ligament by placing the probe in a similar fashion laterally and looking for the similar type of structure coming across the very top of the patella and attaching. So here, again, the lateral retinaculum coming and attaching to the patella, lateral retinaculum coming all the way across on that. In addition, we want to look at the articular surface of the patella underneath on the medial aspect. This is better looked at using the hockey stick probe. What I do in this case is bring the patella over medially, place the probe directly underneath it, the patella, by tilting it, and then getting a view where you can see the hypoechoic nature of the cartilage underneath with the hyperechoic patella.
Here's a blown up view again of the medial patellofemoral ligament attaching to the superior patella, looking at that in greater detail here. Finally, a review of the quiz is noted in the ebook, which we will not review for the sake of this video. We will go to the next parts, the medial, lateral, and posterior parts, in a separate section. Thank you.